Puscast, yet another one. This one covers the last 2 weeks of August in the year 2020. References are available online at edgydoc.com, home of my multimedia empire. Amazingly, I actually made an error in the last Puscast, mostly because I don't listen to what I'm saying. I said in reference to birth control that rifampin inhibited the P450 system, when in fact rifampin induces the P450 system, leading to hypermetabolism of birth control of various types, perhaps including injectables, and leading to perhaps unwanted pregnancies. So the take-home is rifampin induces the P450 system. It doesn't inhibit the P450 system. And I actually went back and just listened to this, and I was right this time. Anyway, let's move on to the literature, shall we? And let's have a new drinking game. Every time I make a mistake, have 2 ounces of Maker's Mark. I usually don't talk about pediatric studies. I am an adult doctor who I treat and not necessarily how I behave. As I like to say, you're only young once, but you can be immature all your life. However, this study out of Switzerland concerns what constitutes a fever in children with neutropenia in chemotherapy. And this is using tympanic temperatures. And they found that for kids in chemotherapy, 39 was fine as your cutoff for fever, except for those with AML or those with stem cell transplantation. I'm always a pedant about what constitutes being febrile, so at least in kids getting chemo for cancer, a tympanic temperature of 39 should be when you jump into action with a fever workup. So, what's up with COVID in the last 2 weeks? Again, tremendous numbers of papers, and these are the ones that I think are at least curious or of value. And the first is asymptomatic transmission. And most of you know around 40% of COVID patients are asymptomatic, but it was how this patient acquired their COVID. They were on an airplane flight with a bunch of other asymptomatic patients. They were all wearing N95 respirators, except at, here's the key thing, meal times and using the toilet. The patient with the asymptomatic COVID was eating dinner at the back of the plane next to the restroom. And the only time the person who got COVID was exposed was when they went to the bathroom and took their mask off. So, wandering around the hospital, when are people not wearing their masks? Well, I know for sure they're not wearing masks while they're eating. I know how many times I've tried to put a maple bar in my mouth when the mask is on, and I can tell you with great certainty it's difficult to eat a maple bar with a mask on. Although when I eat, I take in a breath, lift the mask up, take a bite, put the mask down. But I wonder how many people take the mask off when they are alone, when they are not using the bathroom. So, nature calls, you go to the facilities, you take your mask off. You put your mask back on when you leave, but you flooded the bathroom with COVID particles. Then the next person comes in, they take their mask off, and voila, or maybe it's viola, and they're exposed to and acquire COVID. Unfortunately, toilet stalls are not good places to do observational epidemiology. There are a lot of reasons to hold your breath when you're in the bathroom. I think I just found another one. But really, wear your mask when you're alone in the toilet. And there was another epidemiology of an asymptomatic patient who gave COVID to at least 71 other people, including patients in hospitals. As we head into the Labor Day 3-day weekend, I look forward to another massive spike in COVID patients, thanks predominantly to the asymptomatic patient. Good news, SARS was transmitted to a cat in Belgium who became symptomatic for COVID-45, but unfortunately did not succumb to the illness. There continued to be a smattering of cases of COVID-45 being passed on to animals, but really it doesn't seem to be a big source of infections in humans yet. By the way, I am recording this podcast on the front porch because it's a hot day here in the Great Pacific Northwest, and my son's bulldog is snoring next to me. So that's not me making those sounds, it's the dog. We have tried to put a mask on Winston, but bulldogs don't like to wear a mask. I have spent the last 5-6 months taking care of COVID patients, and to date, I don't think I have caught the illness, and no one in my household has had any respiratory illnesses, including Winston the dog, though how would you know in a bulldog? They have all these horrible mutations to make them look the way they do, including a shitty respiratory system. The study looked at the seropositivity rates in healthcare providers in 13 different academic medical centers in the United States, and 6% had evidence of a prior COVID infection. And around a third, usual number, did not remember having any symptoms of COVID-45. But, surprise, surprise, wearing a mask was protective. Those who did not regularly wear a mask had a 9% seropositivity rate versus 6% in those who were compulsive about wearing masks. And if you were in a hospital that had PPE shortages, you were more likely to be seropositive than those who are well stocked. Further support, as if we needed it, that masks are a good way to prevent the spread of COVID-45. And a study in emerging infectious diseases suggests that you can decontaminate your N95 3 times by UV light and 1 to 2 times by dry heat and still maintain structural integrity. Since, to judge from the supplies in my hospital, we are still scrounging for supplies. Although, fortunately, we remain low in COVID cases here in the Great Pacific Northwest. That being Oregon, of course. Not so much Washington. And the most interesting article, I think, for the future came out of Hong Kong, where COVID hit at the start of the flu season. And when people used social distancing, masks, etc., their flu season, quote, ended abruptly with a decrease to a low trough, end quote. So you wonder what that means for the flu season coming up in the United States. If people don't wear masks and socially distance, we're going to have the horrible combination of influenza and COVID at the same time. But if we mask and socially distance, are we going to have a negligible flu season? And if so, that would kind of imply going forward that every flu season should be mask and social distancing season, like they do in parts of Asia. Of course, this is the United States. We're not going to wear masks or get that damn vaccine, are we? I always remember that people took great affront when I said that healthcare workers who did not receive the flu vaccine were dumbasses. Well, when it comes to COVID, when it comes to some of the responses to COVID, that's a much too mild a term. In a study in kids for treating influenza, baloxavir was quite effective. However, a single dose led to 23% emergence of a mutation that markedly decreased the effectiveness of baloxavir. And this was at a higher rate than seen in adults. So this looks to be a drug that we will probably be able to use once or twice. And then like amantadine, we will no longer be able to use baloxavir for the treatment of influenza. And an interesting epidemiologic study that showed that the nature of the respiratory microbiome affected the susceptibility to influenza infection. And it varied between influenza A and influenza B. I don't think I'd want to gargle a Prevotella or Streptococci, although there have been studies to use strep sprays to prevent infections in children. But I have to admit, I never thought that the oral microbiome or the respiratory microbiome would have much to do with how infectious influenza could be. It's interesting, but it's in one of those, so what are you going to do about it studies. So after you go through all the hassle and expense of getting hepatitis C therapy, you can get reinfected. And in Germany, one of the important risks is men who have sex with men. And they found it to be the only risk factor that mattered. And while you think of hepatitis E as predominantly an acute illness like hepatitis A, the Fonzarelli hepatitis, Patients can get chronic hepatitis E. They usually have severe immunoincompetence, such as organ transplantation. And surprisingly, ribavirin is very effective in organ transplantation in eradicating hepatitis E. I say surprising because ribavirin has been tried on every virus and works on virtually none of them. But at least in this population, we have an indication for ribavirin. For example, after a course of medications, 80% had a sustained viral response, which is pretty good. I remember back in 1990s, yes, I'm that old, and the discovery of the hepatitis G virus, or the GB virus type C. This virus is not uncommon in human beings. It doesn't cause hepatitis. And for years, no one knew what this particular virus did. It is now in the Peggy virus family, and it is spread from human to humans through parenteral, sexual, and perinatal routes. It is a virus that can persist for years like hepatitis C, although many people will clear their viral infection after 2 years. However, what it is associated is with lymphoma of a variety of types, including large B-cell lymphoma, follicular lymphoma, marginal zone lymphoma, and T-cell lymphomas, and to a lesser extent, Hodgkin's and chronic lymphocytic leukemia, neither of which reach statistical significance. But it would appear that the Peggy virus may have a role in inducing lymphoid tumors. I believe it's what done in Buddy Holly. A nice study demonstrating that prior syphilis makes subsequent episodes of syphilis less symptomatic, both clinically and objectively as judged by the amount of syphilitic DNA in the blood or RNA in the spinal fluid. What was amazing, though, was that 155 patients had 2 episodes of syphilis, 43 had 3, 15 had 4, 8 had 5, 1 had 7, and 1 had 9 different episodes of syphilis. Human behavior can be quite interesting, and people evidently don't learn well from past experience. But the real take-home is that in patients at risk for syphilis, a lack of symptoms is not going to rule out a new episode of the disease, and in patients with risk factors, you should do routine screening. Patients with bacteremia from a variety of etiologies can have a rapid step down to an oral agent. This study looked at a quinolone versus a beta-lactam and found them to be essentially equivalent, with a 93%-ish effectiveness. It's interesting is that they compared beta-lactams to a quinolone and found that the beta-lactam was non-inferior to the quinolone, rather than the other way around. I have personally never trusted quinolones for most streptococcal infections and have always tended to avoid them. The other note in this study is that you should give high-dose beta-lactam antibiotics, but I think you should always give max dose of whatever it is you give people orally. But also, people should get at least 3 days of IV therapy before they get transitioned to oral to maximize the cure rate. After treatment of gonorrhea, how long should you expect to have symptoms? 2 days if it's gonorrhea, 3 days if it's gonorrhea and chlamydia. And 90% of people will be all better within a week. Women also tended to take longer to get better, 4 days, rather than men, 2 days. But it is always nice to be able to tell the patient how long they will be ill. A nice review in Clinical Infectious Diseases on does this patient need blood cultures? And the most important aspect of blood cultures in the last decade is that in patients who have streptococcal infections or in whom have gram-negative infections with good source control, you don't need to repeat blood cultures to document clearing. It is a waste of time. The only times you really need to repeat blood cultures are for staph bacteremia and to a lesser extent Candida bacteremia, but for the rest of the time, it's a waste of time. except under certain select conditions for which you should probably be having an ID consult anyway, such as endocarditis or other endovascular infections. Although I have to say, even with endovascular infections, I don't think I've ever had a repeat positive bug culture in someone with a streptococcal infection if they've received but a single dose of ceftriaxone. A study that looked at the long-term outcome of patients with prosthetic valve endocarditis who did not have surgery, and they did surprisingly well. If you consider a 24% mortality rate at 1 year, surprisingly well. But I was surprised at how good the relapse and reinfection rates were, which was a mere 5%. But it was the enterococcus that was associated with a higher risk of relapse. I've often wondered about putting patients with prosthetic valve endocarditis on chronic suppressive antibiotics. I have tended not to do that unless I was also worried about a concomitant pacemaker infection where there is some retrospective data. And TAVRs have been a particular nightmare. I think they are an infectious disease employment act because you know these patients are not surgical candidates from the get-go. That's why they have a TAVR. And the number one cause of endocarditis in these patients is enterococcus in some series. So I have tended to put them on oral amoxicillin suppression after talking to the patient about the pros and cons. I don't know if that's the right answer, but one wonders if you should do that for prosthetic valve endocarditis in general, if it is the enterococcus. Okay, this is probably the most important article I'm going to talk about this week. So, listen up. We use way too much vancomycin, and people fret way too much about MRSA. And here is a nice study that looked at the negative predictive value of an MRSA nasal swab. And I'm going to quote from the article. Quote, the NPV for bloodstream infections was 96.5%, for intra-abdominal cultures, 98.6%, for respiratory cultures, 96.1%, for wound cultures, 93%, and for cultures from the urinary system, 99.2%, end of quote. And of course, there was the study that showed that if you had a negative screen, you almost certainly did not have MRSA in the diabetic foot. So in patients with negative screens, you can either stop the vancomycin ASAP or preferably not even start it at all. And that's generally a good rule about staph when it comes to cultures. If you don't grow it, it ain't there. Staph aureus is not some fastidious little wimp of an organism that doesn't grow out. If it's causing pathology, you'll grow it. Others have probably heard my conceptual framework for meta-analyses. And in a meta-analysis, what you do is you take all the piles of BS, you put them in one great big pile, and instead of getting a large pile of BS, you get spun gold. So I always take my meta-analyses with a grain of salt substitute. This one looked at the benefit of adding an adjuvant beta-lactam to your vancomycin or daptomycin treatment for MRSA bacteremia. And the results were fairly unimpressive, that maybe it would help with a variety of outcomes such as clinical failure, bacteremia recurrence, and persistence of bacteremia. And it did shorten the duration of bacteremia, but it did not alter crude mortality or nephrotoxicity, and may have been increased the risk of C. difficile. And they also suggested that of the combinations, it's the cephalosporin plus daptomycin that may get the most bang for the buck. I don't know. It's a messy literature. I have occasionally tried combination anti-staphylococcal therapy when I've had primary failure, and that's about once a blue moon. But I think it's safe to say that as of the year 2020, we still don't know what the optimal way is to kill MRSA, or even MSSA, given issues of the CIE. But then that's the nice thing about being a specialist. The more you know, the more uncertain you are about what the hell it is you're supposed to be doing. Being a specialist is being comfortable with your ignorance. Yes, it's nice to be such a philosopher. Hand me my pipe and smoking jacket, will you? I bet you didn't know that all philosophers smoked a pipe and wore a smoking jacket. And that's what happens when the burning embers from the pipe fall into the pockets of the jacket. You get a smoking jacket, right? The general rule of thumb is that resistant organisms are less fit and don't survive as well in an environment where they have to compete with non-resistant organisms. Unfortunately, the USA 300 strain of MRSA seems to have proven that bit of wisdom wrong, but it does seem to be the case with the Enterobacteriaceae that make carbipinamases. They looked at 21 patients to see how long it lasted, and the mean duration of carriage was 86 days. Not too bad. And most people were without their CRE within 1 year. I often say for infections like herpes that, unlike love, it is forever. But that would not be the case of carbipinamase, producing Enterobacteriaceae that last about as long as a teenage romance. There is nothing like organisms that grow in antibiotic or antiseptic solutions. There was an outbreak, actually 2 outbreaks, in peritoneal dialysis patients that were due to contaminated aqueous chlorhexidine, and they all contained Burkholderia cepacia. Amazing, huh? I think the take-home is, given the ubiquity of chlorhexidine for line and other antiseptic purposes, if you see a Burkholderia species in your line infection, look to your chlorhexidine. The study was out of Hong Kong, so I presume that the products came from China. So I do not know how applicable that might be to products coming from other countries. But it remains a possibility because bacteria don't give a rat's posterior about geopolitical borders. So C. difficile remains a problem, and this particular study gave either vancomycin or placebo in patients at high risk for developing C. difficile. They had a computer-based risk prediction model that decided who would benefit from perhaps vancomycin versus placebo, and they found that oral vancomycin prophylaxis for these patients prevented C. difficile. Normally I would have said, that's only going to drive resistance, but if you remember the last Puscast, we talked about, and by we I mean I, a study that showed that vancomycin orally did not drive VRE. And generally speaking, I think that antibiotics as the modality by which you prevent infections is always the last resort, and because you cannot do other interventions appropriately. But that's probably not the case with C. difficile. The big question is how to apply this particular study to other institutions. So while I'm generally not in favor of prophylactic antibiotics as a intervention to prevent infections, except in well-defined situations, this one is quite interesting. One of the several themes of infectious diseases this millennia is that IV antibiotics are overrated. This study looked at Klebsiella liver abscesses and whether or not you could give IV or oral. And oral ciprofloxacin and IV ceftriaxone were equal in their efficacy in treating Klebsiella pneumoniae liver abscesses. 2 things of note in the study. Most patients had 5.5 days of IV therapy, and 70% underwent abscess drainage, which is not always practical from a mechanical point of view. But the results of this study would suggest that once you've drained the abscess, if you can, and they've had 5 or so days of IV antibiotics, if susceptible, you can switch them over to oral ciprofloxacin with the same outcomes. While I still don't believe the oral for endocarditis study, and that's a whole different topic, it is impressive how many infectious diseases do not need long-term IV therapy for resolution. I'm sometimes surprised at the results of study. This is one that looked at what happens if someone develops active tuberculosis while they are on therapy for latent tuberculosis, which I would not think would happen, but does. But I think the interesting thing is that patients did not develop drug resistance as a consequence of being on latent TB therapy when they developed their active TB. I keep trying to say the word specifically and messing it up. This specifically relates to rifampin monotherapy, which resistance did not occur, which was surprising but encouraging. So not all exposure to MTB leads to either active TB or latent tuberculosis. And you can be transiently exposed to TB in all probability and not develop disease or latent disease. This study looked at what happens in kidney transplant patients, and those who've had kidney transplants are more likely to go on to develop latent TB after their transplantation. Now, this is a study out of Taiwan where there's a lot more tuberculosis than in the United States, but it's interesting in that it probably shows that patients who are somewhat immunocompetent are more likely, when exposed to tuberculosis, to go on to develop latent TB than normal hosts. How much this applies to your practice in kidney transplant patients depends upon how much tuberculosis is in your community. In Portland, not so much. So I'm about to mispronounce this. There's a yeast called Saprochaete, Saprochaete clavata, clavata, that caused an outbreak in a cancer center because it was in the dishwasher that was washing the dishes used by cancer patients, and once the dishwasher was decontaminated, the outbreak went away. I've not heard of this particular yeast before, but honestly, there is, at least, especially thanks to the MALDI-TOF, a new organism I learn about every 5 days anymore. And from the article, this organism, previously caused Geotrichum clavatum, is a rare emerging pathogen, an asomycetomatous yeast-producing arthrochlamydia that causes invasive fungal infections in immunocompromised patients. So many organisms to worry about out there. And this one coming from a dishwasher. A podcast or so ago, there was a meta-analysis that showed that smoking marijuana was associated with increased risk for Aspergillus, Mucor, and Cryptococcus, which I have seen in my own practice. This study looked at smoking as a risk factor for invasive fungal disease, and smoking is a risk factor for the development of invasive fungi. And they suggest it is bad to smoke tobacco, marijuana, opium, and crack cocaine, especially if you have HIV or hematologic malignancies. And a surprising number, well, maybe not so surprising, number of cancer patients smoke marijuana for symptom relief, and with that comes a risk of invasive fungal infections. And that brings this particular Puscast to a close. References are available online at edgydoc.com, home of my multimedia empire. There are references to articles that I did not talk about on the Puscast that may be of interest to you. Otherwise, thank you as always for this most interesting consultation. Allowing me to participate in the care of this most difficult and challenging case. Shall continue to follow along with you. Thank you in dictation, and as always, take it away, Jeff.